Hi everyone. Today I'll be talking about COVID-19 with pathophysiology and mechanism of disease in relation with cardiovascular system and the diagnostic dilemmas it can provide or present in various presentations of cardiovascular disease like chest pain, shortness of breath or heart failure. COVID-19 or SARS-CoV-2 is a viral disease, as we all know, that started from Wuhan in China and spread all across the world, claimed many lives and still ongoing in many parts of the world. It has a mortality that is high in those people with pre-existing cardiovascular conditions, including coronary heart disease and hypertension, and those with increasing age. COVID can mimic heart disease. It can mimic acute coronary syndrome or heart failure. On the other hand, COVID can actually precipitate acute coronary syndromes and heart failure by its disease process by itself. What is the pathophysiology involved here? Then what are the mechanism of cardiovascular manifestation of COVID? The virus, the COVID or SARS-CoV-2, it can directly affect the myocardial cells and damages them and multiply inside the myocyte, causing damage, which may lead to heart failure, myocarditis during the infective process. And there is something called a cytokine storm, where the active immunity of the host or the virus plays a major role. When the virus infects the cell, various cytokines like interleukin 6, interleukin 2 and interleukin 7 are secreted by the macrophages, which produce a systemic inflammatory state, and this causes damage, inflammatory response in the body, and which can result in increased vascular permeability. ARDS, systemic inflammatory state itself, cause instability of the plaque and plaque rupture, precipitating acute coronary syndromes and myocardial infarctions. And if you look at other mechanism of action, how cardiovascular system is implicated in COVID is by indirect means. The pneumonia itself increases the oxygen demand and stress on the cardiovascular system, on the heart, which can lead to ischemia and worsening of cardiac failure, heart failure indirectly, and even cause type 2 myocardial infarctions. We also see that there is an increased tendency for arrhythmia in COVID. This is because of myocarditis per se can cause irritability of the myocytes and produce more of arrhythmia. It has been seen that more than 16% increase in arrhythmic events in COVID infected patients compared to those who are not infected. Now, what are the diagnostic dilemmas involved in cardiology in COVID times? Perhaps someone presents with chest pain. Chest pain can be either a manifestation of an acute coronary syndrome or it can be a manifestation of COVID itself. Shortness of breath. Obviously, pneumonia can cause shortness of breath, heart failure can cause shortness of breath, and COVID can also present as shock. And if you look at the chest pain patients, chest pain itself can be associated with an abnormal ECG and elevated troponins. Elevated troponin, in fact, is seen in those people with COVID without any cardiovascular acute coronary syndrome, because of the action of the virus itself on the myocardium can release troponins to the tune of up to maximum 3 times the normal values. Mild to moderate elevation of troponin can be a marker of the virus itself, doesn't implicate that there is an acute underlying coronary syndrome. But marked rise of titers of troponins usually indicates an underlying heart problem like acute coronary syndrome. more than 5 times the upper limit of the troponin indicates an underlying coronary syndrome usually. An abnormal ECG can itself secondary to an acute viral myocarditis rather than an acute myocardial infarction. But if you look at the ECGs, if it shows regional or ST elevations or ST depressions indicating a particular vascular territory, and then perhaps associated or pure acute myocardial infarctions or ACS are more likely than a myocarditis causing ECG changes. Shortness of breath, of course, can be secondary to pneumonia or acute respiratory distress syndrome, ARDS, but it can be also due to heart failure secondary to myocarditis, or heart failure secondary to an acute myocardial infarction. And shock-like presentation is also known to be one of the presentations of the COVID. It can by itself cause shock and circulatory collapse because of various mechanisms. It can be due to septic shock, or it can be due to even cardiogenic shock secondary to an acute myocardial infarction. So, distinguishing and going in a correct direction, identifying the particular disease that is causing these presentations may be challenging in COVID times. So, what we can do to identify and manage such people? The first and foremost is by through an epidemiological as well as clinical assessment determining the probability of COVID in a particular given patient. If the patient is coming from an area where the COVID is rampant and he has got any previous contact with a person who is known to have established to have COVID, his probability is more than 60 to 70% than an ordinary person. So, we have to look into it appropriately. But one other thing is that any patient presenting with any of these presentations, unless otherwise proved, has to be managed as COVID positive with appropriate precautions to prevent hospital related cross infections. So, if you look at the data, we know that more than 70% of infections that is spread to the healthcare worker occurs from the hospitals, from the patients, and of all the COVID transmission, 40% of transmission occurs or occurred in the healthcare setting. Now, looking at the chest pain, if you look at the clinical characteristics of chest pain, the type of chest pain, if it is a typical chest pain which is falling into classically into anginal patterns, probably the patient is likely to have acute coronary syndrome. Whether the acute coronary syndrome per se or an acute coronary syndrome precipitated by COVID itself, because we know that a plaque rupture can happen because of acute inflammatory change that has happened by the COVID. So, such people still has to be managed as COVID positive, unless otherwise we know that the test, that the diagnosis test comes negative for COVID. By the way, any patient presenting with these manifestations, they should always undergo a COVID test, a PCR test. A swab has to be taken, nasopharyngeal swab has to be taken and sent for diagnostic evaluation. On the way, the patient has to be managed till the result is available. Patient has to be managed as COVID positive in appropriate facility, in isolation or in level 2 settings, where there is very less chance taking precautions not to have cross infections inside the hospital. So, appropriate algorithms and appropriate precautions has to be taken. Typical ECG changes. If somebody coming with chest pain with ST elevations in a particular territory, so they are more likely to have an acute coronary syndrome. And in doubtful cases, we can actually do an echocardiogram to assess regional valve motion abnormalities. If there is a particular ECG manifestation of a particular territory, vascular territory, corresponding regional valve motion abnormality in the echo, we know that it is an acute MI, ST elevation MI, and unlikely to be a primary COVID presentation of ECG changes or myocarditis. And more than 5 times elevation of troponin I or troponin T or marked elevation of cardiac enzymes is also suggestive of primary cardiovascular event rather than a secondary to COVID. All patients with COVID, as I said, has to be evaluated by PCR, swabs taken and sent. And they have to be managed as positive cases in isolation till the results are available. It is also recommended that if clinical suspicion is high, epidemiological features are more probable, and the chance of COVID is more than 70%. If the initial swab comes as negative, even a second swab after 48 hours is recommended. And then accordingly, we have to manage this patient medically, medical stabilization. And if it is an NSTEMI, if it is not high risk, obviously we should manage them medically till the results of COVID test is available. If the patient is hemodynamically stable, no ongoing signs of ischemia with appropriate medical management, they can be continued on medical management till the test results are available. But of course, in a facility with all proper precautions. In STEMI patients, the recommendations, current recommendations mention that all STEMI patients, again, they have to be appropriately managed COVID positive unless otherwise we know the results, and we have to send the swab. And these people, the proper revascularization methods has to be adopted. As we know, primary angioplasty is the gold standard in the management of ST elevation myocardial infarction. But in COVID times, sometimes or most of the time, delays are expected in shifting the patients to appropriate cath labs, which is marked for COVID-19 patients. If delay in transferring to such facility is more than 120 minutes, the best possible way to treat such patients is by thrombolysis, if the patient is not having hemodynamic instability or other urgent manifestations, clinical manifestations, which requires primary PCI as the choice of the revascularization. Most of the time, if the delay involved is more, thrombolizing the patient and waiting till if the patient becomes revascularization is reasonable and fine, we can wait till the results of the swab test is available, and the swab is negative. We can always take him in for angiogram and proper revascularization, completion of revascularization procedure according to the protocol. Such patients can be taken into a normal cardiac catheterization facility, which is reserved for non-COVID patients. If it turns out to be COVID positive, then the patient has to be shifted to a facility dedicated for COVID-19 patients to undergo angiography and proper PCI. So that is how you manage acute ST elevation myocardial infarction. Non-STEMI patients also, as I mentioned, low risk patients has to be managed medically, and high risk patients has to be managed like STEMI patients, to shifting to a COVID-19 designated cath lab to undergo procedures. If they can be medically managed, they medically stabilize the patient, and they have to undergo PCI at a later date when the status of the infection, whether the COVID test is positive or negative, is known. Then accordingly we can manage such patient at a later date. Now, patients presenting with breathlessness, it can be cardiac. Is it worsening heart failure or COVID related myocarditis, non-cardiac, pneumonias, ARDS? Appropriate clinical examination and investigation has to be carried out, which most of the cases will clear the doubts. A chest X-ray can sometimes maybe diagnostic of COVID, because most of the COVID in the X-ray that happens as a particular pattern is there, where the periphery of the lungs are involved. And in suspected cases where the diagnosis is still not clear, we need an urgent understanding of the disease process. We cannot wait till the COVID-19 swab test is available. It takes maybe 1 or 2 days in some of the settings. So we can take these patients for a chest CT. Chest CT is highly diagnostic and sensitive for COVID-related pulmonary involvement. And most of the Chinese studies show the sensitivity is more than 95%, even more than the swab test, which has a sensitivity of 60 to 70%. This low sensitivity to the swab test is attributed to various factors like improper technique in obtaining the sample, improper storage and transportation related problems. However, this does not mean that chest CT is the primary modality of investigation, but in hospitalized patient it has shown at a high accuracy and sensitivity in diagnosing COVID. So, breathlessness patients can be evaluated by a chest CT if the diagnostic dilemma continues. Limited echocardiography will also help to assess the left ventricular function, but always it is imperative to keep a separate echo machine or a portable machine for this particular purpose for COVID suspected patients, and proper disinfection of the equipment is mandatory with each examination, after each examination. The CT scan also, the terminal cleaning is important if we undertake the CT evaluation of such patients. As we discussed at the onset, cardiogenic shock or non-cardiogenic shock may be a manifestation of COVID. Proper evaluation and management in a critical care setup is mandatory with appropriate precautions, which will clear most of the diagnostic dilemmas, and proper management can be instituted. However, the basic aim of managing suspected patients with cardiovascular symptoms in these COVID times is, one, to initiate appropriate management strategies and diagnostic procedures, and the second, almost equally important aim is to prevent any chance of cross infections in the hospital setting, and this is very important as it protects the healthcare workers and other patients admitted in the healthcare facility from getting infected. As we have already seen, 40% of infections, transmission of infection in COVID happens in the healthcare facility. So, it is appropriate to use adequate and proper personal protective equipments in all scenarios, and it is important to proper triaging and streamlining the management strategies accordingly in managing these patients. Thank you.